Okay. Welcome, everybody. I think everybody knows who I am, but I will just introduce. My name is Jensen, assistant professor in the Department of Kinesiology, and my area is in clinical exercise physiology. So majority of you guys take clinical exercise physiology class this moment, or maybe this semester or last semester, or maybe next semester. You will learn about a lot of things about exercise from the exercise clinical physiology in perspective in the people with the chronic or any disabilities, chronic dependent disease. So the reason why we started with the exercise medicine seminar series, one was because this is one of my dreams, studying at the San Jose State. And second, we want to give you a chance, an opportunity to talk to and then to learn about exercise physiology or exercise science related to the many different types of disease. And this year's topic is exercise is medicine. Again, everything is about exercise. Is breast cancer, and we want to look at the effect of exercise. So I invited Dr. Kerri Winterstone from Oregon Health and Science University, and also I'm also invited as a guest speaker for Dr. Linda Wilkin from our department teaching clinical exercise physiology as well. Before I introduce Dr. Winterstone, I want to introduce you about who she is and maybe how I met. I was searching for the topic for the exercise medicine seminar series. Last year we had a type 1 diabetes and we had a great time. This year was breast cancer. I've been thinking about this for past few years, but personally I did not know enough to invite somebody who has expertise in breast cancer and exercise as an intervention and as a treatment. Luckily, the meeting passed in May at ACSM, so American College of Sports Medicine. I checked all the symposiums and everything related to the breast cancer. So I went to Dr. Kerri Winterstone's seminar, and it just hit my head, and then I thought, she should be invited. So that was the first thing that I had. So luckily, Dr. Winterstone agreed to come here make this time. She's very, very busy, but she's here. So she is originally from Fremont. Were you born here?
I was born in Oakland.
Oakland. So she is a Bay Area person. Yes, so she did bachelor's at UC Davis, and she had a Ph.D. From Oregon State University. And right now she's a professor at Oregon Health and Science University, and she's a co-director and a co-leader of the OHSU Night Cancer Institute Community Partnership Program and Cancer Prevention and Control Program. Is that right? I stalked you a little bit. And today, her focus and experience with the research is looking at the importance of physical activity and actually exercise as a medicine, as a treatment. Looking at the people with the chronic diseases, and today Dr. Winterstone is going to talk about the effect of exercise on cancer patients, so breast cancer survivors. She has numerous publications on this topic. I'm not going to go over all this, but we will today learn about how exercise can become a medicine and effective treatment for cancer, breast cancer survivors. So can I introduce you here, Steve?
All right. Well, good morning, everybody. It's nice to be here, nice to be back in the Bay Area, so I appreciate the invitation to come and talk to you. And it's really nice to see students who are interested in this potential field, or at least in clinical exercise physiology. Oregon Health and Science University is not a four-year university, so I don't get to interact with undergraduate students very much at all, or in exercise science. but you are kind of the future leaders and the future workforce to be helping all of these individuals who are aging and potentially going to encounter chronic illnesses, to use the power of exercise to help either prevent and reduce the risk of those chronic illnesses, or to help manage their chronic conditions when they get it, right? Because most everybody's going to get something. But they're really going to rely on you to use exercise as a complementary therapy to be able to help them get through treatment and potentially live longer despite their illness and live higher quality of life despite their illness. So hopefully I can get you motivated a little bit around the topic of cancer. And I know you haven't had much on pathophysiology of cancer, or even what is cancer. And I'm not going to go into that yet, but you're going to get that on the back end, I think, later on in your clinical exercise physiology class. So I'm going to whet your appetite and maybe get your curiosity. And we have some Q&A, so we can talk about it a little bit more during that time. Okay. So it's a little challenging for me to go through an entire field of science in 40 minutes. I'm going to give you what I think are kind of the highlights and things to start kind of getting you interested and curious about this particular field. And I'll tell you, as a student in exercise science, as an undergraduate, I didn't know what I wanted to do. So I ended up continuing to go to school and getting a master's degree. And then I got really turned on by research. I thought it was the coolest thing, because you would have a question that you were really curious about. You design a study to answer your question. You'd answer your question and you come up with 10 more questions, right? So it was this never-ending way to kind of continue to be curious, but also continue to gain knowledge. And when I went into my Ph.D., I actually studied primary prevention around fracture prevention. I never thought I'd work with people with cancer. In fact, I was a little bit intimidated or scared because it seemed like such a serious illness. And I ended up kind of tripping my way into the oncology field by taking a chance to come and collaborate with a woman named Anna Schwartz, and hopefully you'll come across her name at some point. But she had a bachelor's degree in exercise physiology, okay, and then started to pursue her nursing degree at the time she was diagnosed with lymphoma at the age of 22. Right? But she was an exerciser, because that was how she got into exercise science and why she went into that field. And when she was getting treated for her cancer, she would walk around the infusion room with an IV pole getting her chemotherapy. And this is in the 90s, early 90s, late 80s. Okay. And she noticed that she was doing so much better than the other people on the infusion ward who were also getting treated but were sitting in their infusion chairs. So what she ended up doing was pursuing a Ph.D., right, to figure out whether or not exercise could actually be helpful for people when they were going through cancer treatment. Because at the time, what most people were told when they received a diagnosis and started treatment was that they needed to rest as much as possible. Take it easy. We don't want you to do anything too exhaustive, then you won't want to finish your treatment. So the last thing anyone would ever think about is to ask someone to exercise. Okay. But she felt differently because her experience was different. And I'm going to show you a little bit of her data, but she really put this whole clinical dogma around conserve your energy and rest and sit still because you're sick, right? And turn that around by saying, no. We actually, if you move more, you actually might do better, right? And now what we know, what I'll show you, is that our recommendations, even in the clinical world, are changing and evolving because somebody kind of appreciated the power of exercise and then put some science behind it. So I came to work with her, and once I started doing my own studies in breast cancer patients, I was so moved by their experiences and their stories and how grateful they were when you could show them how exercise could help them recover from their treatment, that I knew I was changing my field, and that's where I was going to stay throughout the rest of my career. So I bring that up only because I hope, as some of you kind of explore what your career opportunities, right? When you start working with patients, that they can actually teach you and you can learn from them, and it might be one way to really have a gratifying kind of career out of your program. Okay, so that's my soapbox. And now we'll get to the science. So I think all of you kind of appreciate some of the origins of our discipline, right, have always really been around how do we use exercise to enhance performance. So a lot of early exercise science programs and research were really built around performance enhancement through exercise, right? But now we're moving, and you're in this class now, which wasn't a class 20 years ago in exercise science programs, right? To appreciating how we can use exercise as medicine, right? So rather than training the already healthy athlete to get faster, and sure, that's fun and that will continue to happen. But can we use exercise as therapy or as medicine, right? To help people who are struggling with an illness. And so in the context of cancer, what I'll go over is how, just very, very briefly, because this is a chronic illness class, not a prevention class, right? But we can talk about exercise to reduce the risk of chronic diseases, right? But then I'll spend most of my time talking about how we use exercise to help manage symptoms, right? So those are things that people feel or experience, right? These symptoms like tiredness and depression, right? Or weakness, right? And then to control some of the side effects of the treatments that they receive, right? Because a lot of treatments, particularly in cancer, are effective, and we've shifted the needle in terms of how many people live after their cancer diagnosis, and they live for quite a long time. But the consequences that sometimes is that people end up with a lot of side effects from the treatment that impact their quality of life. Right? And then most chronic illnesses, they're chronic because they develop over time. So individuals tend to get diagnosed, and particularly in the case of cancer, at a later age. So they're already experiencing some of the effects of aging, right? And now are experiencing on top of that the effects of the illness itself, as well as the treatment for those illness, right? So you actually are kind of working with two different stresses to that individual, right? They're already fighting aging, and now they're having to fight this chronic illness and all of the things that come with it. And then what if we could actually use exercise as true therapy and change the course of a disease, right? You're all familiar with cardiac rehab, right? Okay, nod your head. So cardiac rehab is funded and insurance companies pay for it because it changes the course of disease. I have to be honest, insurance companies don't really care if exercise makes you feel better. It is not worth their money because it makes us feel better. If it helps to reduce medical costs, right, and keeps people out of the hospital and prevents future events that are costly, they'll pay for it. Right? So if exercise, we can show that exercise can change the course of cancer as much as chemo or radiation therapy or surgery, we might be able to get it paid for. Right? And when it's paid for, it's much more likely that people are going to be able to access it and use it. So that's where exercise medicine is trying to head. And I apologize, I moved platforms from a Mac to a PC, so things look a little distorted at times. But when we're talking about exercise and cancer, we can kind of think across the, what we call a cancer continuum, right? So starting with prevention, and again, I won't focus on this much at all, but then looking at once someone is diagnosed, what's their prognosis, how long will they live, what's their expected survival, okay? And then importantly is what's the quality of life that they have, right, during that time period. Because what you don't want to do, it might be fine to save a life, but if people's quality of life is really poor, right, that is not as desirable an outcome as if we help people live longer and better, right? Or maybe we don't help them live longer, but they live better for the time that they have. Right? All important outcomes. So if we look at exercise kind of across that continuum, can we come up with a prescription? Right? So what is the type of exercise that might affect, kind of alter this continuum? How much do people need to do, right? How often they need to do it, and when is it important? Does it matter if you exercise before you get diagnosed, at the time you're diagnosed, during treatment, after treatment, at the end of life? Okay. So what we want to do is kind of develop these exercise prescriptions so that we can address a lot of the issues that people face across that continuum. Okay. When we do that, then we can create kind of the pieces that are important for implementation to actually make this affect people and the public and people who've been diagnosed with cancer. So that results in public health guidelines, which I know you all know like the back of your hand, right? What those are. But policy, right? Insurers, programs, clinical practice. So all of these other pieces that have to come together in order to make sure that the public has access, right, to the benefits of exercise. So here's my obligatory slide on exercise and cancer risk, because we want to spend our time on survivorship. Okay. But this is where we have some pretty good evidence that has contributed to our public health guidelines, right? That regular physical activity significantly reduces the risk of many types of cancer. So I don't know if you guys are familiar with incidence or relative risk, but anytime in this case, right, any value above 1 means there's an increased risk, and any value below 1 means there's a reduced risk, right? And what I'm showing here are data that show the difference in risk of cancer between people who exercise regularly and people who are sedentary. Okay? So for people who exercise regularly, the relative risk of getting any one of these cancers is below 1, right? Which means that it's lower. Okay, so regular exercise reduces the risk of colon cancer, breast cancer, prostate, ovarian, and endometrial cancer, which are among the most common cancers that individuals may get in their lifetime. Okay. So this is pretty strong evidence, and this is what's informed our public health guidelines. Right, for 150 minutes of moderate to vigorous intensity aerobic activity every week, right, because they contribute to a lower risk of cancers, as well as other chronic illnesses, right, heart disease and diabetes. But what you may not know, and what's been really exciting in our field for the last 10 years, is that exercise may actually be able to lower the risk of someone's cancer coming back, or of someone dying of their cancer. Okay. So these are relatively new findings in this field, and I put it up front because I think this is what the exercise oncology field is really excited about, because if we show that exercise can change the course of an illness and help people live longer, then that's our sweet spot for getting money, right? For getting reimbursement. So I'm going to start here, and then I'm going to get to the other important stuff. But there have been a lot of studies that have been done over the last 10 years, and these are what we call epidemiologic studies, which I don't know how familiar you are with those types of studies, but these are observational studies where large numbers of people are followed over many, many years, and we ask questions about their diet and their physical activity levels and environmental exposures, right? All things that might impact whether or not they get a chronic illness. And then we track them over time and find out who gets a chronic illness and who doesn't. And then try and draw associations between those behaviors and whether or not they got a cancer. So this is the same type of study where individuals are followed over time until they get a cancer or not, and they continue to be followed over time. And those individuals who were diagnosed with cancer, now we're following them and seeing the people whose cancer comes back. Does it come back sooner in people who have certain behaviors compared to other people who have less healthy behaviors? Do they die of their cancer sooner or later than other people, depending on those behaviors? Do they die of any cause sooner or later than other people? So there have been a series of these types of cohort studies that have been done in people who've been diagnosed with cancer. And what we're starting to see is something that even our medical oncologists, their eyes open really wide about, which is if you compare people who report 3 to 5 hours of physical activity per week to people who report less than an hour of physical activity per week. Individuals who are diagnosed with breast cancer, their risk of dying from their breast cancer is 40% lower if they exercise a lot, right? That's a fair amount. It's 40% lower from dying from anything, including cancer. This we already know about. This isn't new information. And they're less likely to have their cancer come back than individuals who don't exercise much at all. Okay. We're finding the same thing with prostate cancer, most common cancer in men. Less likely to die from their cancer, anything else including cancer, and slows their cancer progression. Their cancer come back later if they're exercising. I mean, this is amazing stuff. This is really exciting. But what's the problem with these data? You didn't know I was going to ask you a question, but what's the problem with this kind of observational data? I only said that they were associated with one another, right? Did I say that exercise, go ahead.
Correlated, not causative.
Thank you, yes, no cause and effect, right? So I didn't take a bunch of individuals who were diagnosed with cancer, exercise half of them, and not exercise the other half, and then follow the course of their illness, right? So it could be that people who report a lot of exercise also are more likely to go back and get their mammograms and their PSA tests, and they might be more likely to eat healthy food, right? So there might be other things that are contributing to their better outcomes than just their reported activity. Right? The other problem is that they're reporting their activity. Right? So they could be truthful or they might not be truthful, and we really can't tell the difference. So while these are incredibly exciting, they don't necessarily establish, right, a cause and effect yet. But isn't this worth pursuing? Because if you tell an individual who is diagnosed with cancer that if they start getting more active, they might live longer and beat their cancer, right? They might be more likely to get physically active than if you tell them it probably will make you feel better and you know you should get exercise anyways because it's good for you. Okay. So these data are really exciting. There have been 30 types of studies that continue to show this repeated potential benefit of exercise on cancer survival. So 75% of those report a link between physical activity, right, and cancer-specific mortality as well as all-cause mortality. Right? The evidence is strongest for breast cancer and colorectal cancer, so two different types of cancer, but it's growing for these other studies. Right? Some of the reasons why we know more information about breast cancer and colon cancer and prostate cancer is because those are the very common cancers. So there's lots of people to study. And it takes longer to do the science on less common cancers. Okay. So stay tuned on those, but there's a lot of interest in that. Okay. And the amount of risk reduction is not small. So the amount of risk reduction ranges from a 15% lower risk of cancer-specific mortality to 67% lower. I gave a similar lecture like this alongside one of our medical oncologists, and he goes, holy cow, that's better than how we treat patients right now. Right? So if we could, I don't know that we'll ever substitute exercise for conventional cancer therapy, right? But if we could prescribe it alongside conventional cancer therapy, right, we might really be able to beat this disease, right? Or give people much better odds. Now, the trouble right now that I see is that the amount of exercise that it takes to have this effect is still pretty high. Right? So around 3 to 5 hours of moderate to vigorous physical activity per week. Is that more or less than what our current guidelines are? It's a heck of a lot more. And people have a lot of, our public has a hard time just achieving those guidelines. Now, maybe once we start doing trials, we'll see that it doesn't take quite as much to have an effect. We'll be able to do better science to see how much is enough. What's the minimum amount people have to do in order to benefit? Because that's really what we want to try and put out there, right? What's the least amount you have to do? And then is there a dose response? If you do more, do you get a better outcome? Right? That's what people want to know. So when I give talks to breast cancer patients and prostate cancer patients and I show them these data, they look at me and they say, tell me what to do. Just tell me the program I'm supposed to do and I'll do it. Right? So our job is to get that information to them because they want to actively help change the course of their disease. So right now across the world, there are 5 large randomized controlled trials, so that's the RCT acronym, right, that are trying to answer the question of whether or not exercise can extend cancer survival. So there's 2 studies in breast cancer, 2 studies in prostate cancer, and 1 in colon cancer. And these are worldwide studies, literally across the world, right? So we are a participant in a study funded by the Movember Foundation, which in the month of November, you'll hear about Movember, because that's the mustache foundation. So one of the ways that they've used the funds that they've raised from the Mustache campaign, the Movember campaign, is to fund a $10 million randomized controlled trial across the whole world to answer the question of whether or not exercise can extend survival for men with prostate cancer. Okay. And there are 11 sites in the United States, and it's headquartered out of Australia, but there are sites in Singapore and Germany and the US and all Canada, all across the world trying to answer this very important question. Okay, so people are hot after it. And maybe if I come back here to a next class, we'll have a better answer. But what these studies are doing are these randomized controlled trials are the most rigorous types of science we can do to show that something causes some outcome, right? So we get a bunch of men with prostate cancer, half of them, flip of a coin, go to exercise, the other half, flip of a coin, don't get any exercise, and we follow them over time. Okay, 1,000 men will be enrolled in that trial, and then we'll see, and we'll track the endpoint as survival. So we're not measuring fitness or functioning, we're measuring survival, right? See that outcome. So keep on top of that information, because it's really exciting. So some of the reasons, like why would exercise help slow down cancer? How does it work? What's the mechanism, right? Because when you start to accumulate evidence for the effect of a health behavior on something like a chronic illness, it starts with those observational studies like, that we keep seeing this over and over and over again. We need to go figure that out. Then we do the trials, but we also have to know why and how. Because if we can't explain that, can we really believe in it? So those are the mechanisms, right? So exercise is doing what, and that what is changing cancer. What is it doing? Okay. So there's a lot of theories out there right now. And cancer's complicated. You will learn that cancer's pretty complicated, right? I think it's more complicated than heart disease. But there are a lot of different ways that exercise might be changing cancer. We know that cancer, both if you get it, what we call a primary, so that's the first diagnosis, or recurrence, the second diagnosis, so your cancer came back, right, can be influenced by someone's immune function. So breakdowns in the immune system, changes for breast and prostate cancer, testosterone and estrogen levels, okay? Insulin and IGF axis hormones, the growth factors, right? You guys know those because they build muscle, but they also help facilitate the growth of cancer. Okay. Whoopsie. Inflammation. So you probably hear a lot about inflammation, right? Is a cause of many evils, right? Including cancer. So this inflammation or excess oxidative stress, right? They used to think excess oxidative stress caused cancer, but then every distance runner would have cancer, right? They create a lot of free radicals, right? But some disruption in that you can produce a lot of free radicals and they're tolerable as long as you can repair them. So there's some breakdown potentially in the repair mechanisms, and that facilitates cancer to keep growing, right? These are all possible reasons, and I haven't even listed them all, right? There are more. Blood supply to cancer, right? Many more. But what you guys know is that exercise changes all of these things, right? Exercise improves immune function, right? It can reduce estrogen and testosterone levels and maybe boost it, but we won't go there. It changes the IGF axis, another complicated one. But it's anti-inflammatory, potentially, right? So we know that exercise causes X and X influences Y, and so these might be the pathways, okay? We also think that body composition might be kind of an intermediate too. So maybe exercise isn't directly affecting these, but it affects weight, and weight in turn affects these, and then these affect cancer. Right? So I bring this up because I'm more of a musculoskeletal systems person than a cardiorespiratory person. And I'm really interested in, our focus in this country a lot is around weight and excess body fat and those effects on chronic illness. But we actually are starting to think in cancer there might be a role for lean mass, okay, in survival. And so look at these data over here, which are pretty cool. These are called survival curves. So you follow individuals kind of categorize them into different groups, and then you follow their actual survival over time. And so the steeper this curve, the sooner someone's dying, or a group of people are dying, right? And the flatter this gets, the longer they're living. So this was I believe this was ovarian cancer, I can't remember off the top of my head. But they had grip strength measures on everybody and categorized people as the highest 50%, 50th percentile or higher. And then over here are people in the bottom 10th percentile or lower. So the weakest people are here. And the average to stronger people are here. And look at the shape of these curves, right? The weakest people, their curve is steep. They don't live very long. And people who are stronger live longer. Maybe muscle plays a role. Right? Maybe it's important. We know that cachexia is called muscle wasting. It tends to happen at end of life in cancer. So one of the signals that someone is going to die of their cancer is they start to waste away. Right? Not all, but, and so there's something once muscle starts to waste, that is some kind of a trigger. Right? So what if we preserved muscle? Could that be a way to delay death from cancer? Okay, muscle and fat talk together too, so maybe it's a little bit more complicated. But there's some data that have shown that if you take individuals as they're going through cancer treatment and put them in a resistance training program, they might actually tolerate more of their cancer treatment. Right? So maybe exercise isn't necessarily affecting the cancer or the tumor. Maybe exercise is improving their tolerance for their treatment. They get more treatment, more medicine means better outcomes. Okay. So look at these data. This is from a group up in Canada. And they've done a lot of work, Kerri, and what they did was they randomized women, this is breast cancer patients who were going through chemotherapy, into 3 different groups. One group got resistance training, one group got aerobic exercise, and another group didn't do anything. Right? And followed them through the course of their chemotherapy. And what they looked at, this is called relative dose intensity. Right? So that's how much chemotherapy that you're getting. And individuals who were in the resistance training group got the most chemotherapy. Right? Individuals who are aerobically trained got the second most, and individuals who weren't exercising didn't get as much. So what happens when people are going through cancer treatment is it's terribly, terribly, terribly taxing. Right? It's fatiguing, it's the nausea and vomiting and diarrhea and GI distress that happens is really distressing. So some people stop early. Right? They discontinue treatment. So it looks like here, people who are exercising are tolerating treatment better. And we actually know from studies that individuals, when they exercise during their cancer treatment, have less nausea, less vomiting, less diarrhea, they sleep better, they're less anxious and less tired. Right? But remember, the doctor said don't move. Right? But look what happens when you move. The opposite. So relative dose intensity above 85%. So if you get 85% or more of your chemotherapy, it's associated with the best outcomes. And if you look at these groups again, the people who are resistance trained, right, more of them achieved their RDI greater than 85 than people who aerobically trained or people who didn't do anything. So they're predicted to have the best outcomes. Okay. So that may be, maybe we're getting toward that prescription. Right? What would your prescription look like? Right? Resistance training, aerobic training, flexibility training, right? What does the patient need to know? Here's a very recent study that was done that looked at the intensity of exercise. So now we take people as they're going through treatment, this is breast and colon cancer, chemotherapy, and randomize them to 3 groups. One group gets no exercise, which I hate. The ethics behind that are terrible. Okay? One group gets no exercise. One group gets low intensity, more public health guide, lower intensity, 150 minutes of exercise. And another group gets moderate to high intensity exercise. And follow them through treatment. And this time they looked at a lot of different outcomes. I'm gonna focus look here, right? Here's our fidelity markers. So people who did the higher intensity aerobic and resistance training got stronger. People who did aerobic exercise didn't get stronger. People who did nothing didn't get stronger, as we suspect. Right? And then people who did mild intensity exercise got a little bit fitter aerobically, and people who did higher intensity got more fit aerobically. So these are your signals that what they set out to do, they did, right? They trained these people, right? No matter what the intensity, we saw some improvements in their day-to-day functioning, okay? It looked like moderate to high intensity exercise limited their fatigue better, okay? Either type of exercise kept their pain better controlled than nothing, right? This is always interesting because higher intensity exercise, a little bit more pain than lower intensity exercise. As you probably know, people have a hard time just differentiating musculoskeletal pain from other types of pain. I think that's what it might be. But if we go over here to this chemotherapy dose, the amount of individuals who had to reduce their chemotherapy because of side effects and toxicities was the lowest in individuals who did moderate to high intensity exercise. And it wasn't much different in people who did lower intensities of exercise than people who did nothing. So another piece of the puzzle, right? How hard do I have to do it? What do I have to do? Right? To live longer from my cancer. Maybe we're getting there. Okay, so hopefully I whet your appetite on that part. And now I'm going to transition over to from extending someone's life to improving the quality of their life. Okay. So one of the things that's happening in this country and has been happening over time, if you look at the number of people who are living after their cancer, okay, it is has been steadily increasing, right, over the last several decades. And look at how high it is. We're now at 15.6 million people in the US who are living after a cancer diagnosis. That's not a small number. And it's expected to continue to double by 2040. You'll still be in the workforce. So there's a lot of people who are going to be living many years after their cancer diagnosis. We used to think, usually when someone got a cancer diagnosis about 20, 30 years ago, they were told to get their affairs in order because they didn't have long to live. Okay, that is not what people are told anymore, okay, in large part. And that's going to continue to get better as we treat more difficult cancers. Okay. So what the country is going to experience is a large number of people living with cancer for many years who have needs, who want high quality life, even though they've gone through really difficult treatment. And this is a graphic, it's old, but it serves its purpose, okay, of how long do people live, okay? So what we're seeing here, right, the majority of people live less than 5 years, but look at how long people, right, can be expected to live. And these are old, so these numbers are shifting, right? Less here and more over here. So people are living a long time, right? And we need to make sure that they're living the same as they did before they got diagnosed, if not better. That's our goal. Okay. So who is a cancer survivor? The definition from the National Cancer Institute, don't think of a cancer survivor as someone who successfully got through their cancer treatment. So someone becomes a cancer survivor if they're alive at the time they're diagnosed with the cancer, called a survivor, because you didn't die from it. When you didn't die initially from it. That wasn't your initial cause of death, right? Until the end of your life. This is a long time period, right? So that allows us to study people kind of at any point in that cancer trajectory. From the time they're diagnosed, how does exercise help them through their treatment? How does exercise help people recover after treatment? How does exercise keep them healthy for a long time? Can we use exercise at end of life to help maintain their quality of life? Right? So that's the whole continuum that we're talking with. Right? So how do people do, right, in their years in survivorship? Well, one of the things that we've learned over the last 10 to 15 years is that cancer changes people. Okay? And these observational epidemiologic cohort studies I've been talking about also provided us with other information about what the changes are that people experience after their cancer diagnosis. Okay? And what we know, right, is that in this case, we're focused on breast cancer, that compared to other women who've not been diagnosed with breast cancer survivors report more difficulty with day-to-day tasks. Taking care of their house, taking care of kids, right, doing daily chores, housework, right, going to work. Right? So they're having more difficulty. Everything's harder than it used to be. So maybe people need more help. Maybe they stop doing things, right? Your ability to take care of yourself makes you feel functional and independent and kind of happy, right? Once you start needing help with things, it really erodes somebody's dignity. It makes it really difficult. They're also more likely to experience broken bones and falls, right? More likely to have their cancer come back or get a new, different type of cancer, okay? Struggled with weight, so weight gain can be common. Even though I talked about cachexia, this wasting, it only happens at end of life, but a lot of individuals will gain weight during cancer treatment. And then really struggle to become or stay physically active. Okay. So what is it that's happening? Is it just the cancer that's causing all of these effects? Okay. And I don't have time to go into the type of studies that have really shown us not really, okay? Maybe a little bit. But what it really is it's the treatments. And so when we focus on breast cancer, right, there are 4 typical kind of standard treatments that women may get. And I haven't gone into all the new fancy immunotherapies and targeted therapies. I'll spare you. But they're kind of a standard core. And so the first is surgery. So this is a solid tumor, it's a mass, right? And the first order of business is to get the tumor out. Right? So most women will go through some type of surgery, right? But the side effects that accompany that surgery are pain, scarring at the surgical site, okay? So limited range of motion, right? Inactivity, right? Decreased range of motion. I don't have the big one on here, which is lymphedema. So sorry about that. So it's a swelling kind of in the surgical area in the arm, right? And then after surgery, so the tumor gets cut out, then usually individuals will get radiation therapy, okay, with ionizing radiation to really anything that the surgeon missed. Now they're trying to go in a targeted way and kill those other cells, right, around the surgical site. So with radiation therapy, individuals feel fatigued, they have more scarring, burns actually that happen, right, where they're getting irradiated, pain, inactivity, and decreased range of motion. So you should start seeing some themes here. Multiple treatments, same side effect, it just gets compounded and compounded and compounded, right? Chemotherapy, this is the doozy, right? So anything that the surgeon couldn't get out and the radiation beams didn't destroy, right, that might have escaped and has started to circulate someplace else, gets killed by chemotherapy, okay? So that basically is a way to kill cancer cells, and along with it, unfortunately, many other cells that it circulates to. Right, so this is particularly damaging to any cells that have high rates of turnover, like the gastric lining, the hair, okay, but also to nerve cells and muscle cells and bone cells. So there's lots of nausea and vomiting acutely, but fatigue, inactivity, weight loss or gain, bone loss, and peripheral neuropathy, which is a numbness or tingling in the hands and the feet. And then as if that weren't enough, right? Because breast cancer, most breast cancers are what we call estrogen-dependent cancers, and it means that the tumor grows, and part of its growth is fueled by estrogen. Right? So one of the therapies is to get rid of estrogen. And so I call it hypermenopause, because there is estrogen that comes from the ovaries. So if women aren't postmenopausal when they're diagnosed, they get put into menopause with chemicals, with drugs. Okay. And then they take additional medicine that gets any adrenal estrogens that are being produced or estrogens that are produced by fat tissue to try and block all estrogen activity completely. Okay. So that causes bone loss, pretty rapid, pretty substantial bone loss, and weight gain, and myalgias and arthralgias, which are muscle and joint pains, and lots of fatigue. Okay. So I'll show you. This is the only symptom that goes away when treatment is done. Right? So all of these other symptoms, contrary to what I think people are told during treatment, or may want to believe, are that these effects go away when treatment is done. And that's not the case. These problems persist long after people are done with their treatment. But they are cured of their cancer. But they are living with all of these side effects. with not much help. The other thing that we think might be happening, and a result of those side effects, is that cancer is accelerating the aging process. So some of the early studies that I did in my lab were to bring in to kind of figure out what exactly is changing, right, in their functioning. So we brought breast cancer survivors into the laboratory, as well as women who hadn't been diagnosed with breast cancer, and put them through functional tests that you guys have probably done before, right? So a 12-minute walk and a time chair stand test for weakness and a tandem walk test for mobility, right? And what we saw was that in every single domain, women who were treated for breast cancer did poorer than women who hadn't, right? So they couldn't walk as far, they couldn't stand up as many times, and they took longer to do a tandem walk than women who hadn't been treated for breast cancer. And if you noticed, the ages for these women, the women with breast cancer were younger than the women without breast cancer, but they were functioning much, much older, right? The women with breast cancer are also reporting 2 to 3 times as many falls, and we know that these are all risk factors for falls. Right? So something changed, right? Their functioning is changing. And what we think might be happening is that cancer treatment and aging are kind of working this same way to accelerate this phenomenon that we call frailty, right? Which is kind of this accelerated aging geriatric syndrome. And that may be part of what's causing some of these outcomes that people report. I'm falling down more, I'm breaking more bones, things are harder. Okay? Because cancer treatment made them age faster. Okay? So in women with breast cancer that we've seen, we've kind of characterized them as, are you frail or pre-frail? So it's kind of a warning, right, to frailty or not, right? And what we've seen is that women, even in their 50s, a high amount of breast cancer survivors are kind of in this pre-frail or even frail state. And this is a group of women without cancer, and our breast cancer patients have more rates of frailty, right? So this aging syndrome. The other thing that happens is that cancer can cause new problems. So we accelerate the aging process, but maybe add on some new insults. Okay. And I'm going to condense this here. I want to make sure we've got enough time. Okay. So we, in our lab so far, have brought probably 600 breast cancer survivors through our laboratory for exercise studies and for other studies. And what we did was we asked women whether or not they were still experiencing the symptom of peripheral neuropathy. So this is, if your foot has ever fallen asleep, it might be falling asleep right now, right? And it feels like pins and needles, and it's kind of numb, right? And you can't walk, you couldn't stand up or kind of walk around until that numbness and tingling goes away, right? That's what neuropathy feels like, but a heck of a lot worse, right? It feels like pins and needles and burning and numbness. And you cannot feel the ground you're walking on. And 45% of the women who'd gone through our laboratory were still experiencing those symptoms, even though they had been diagnosed and treated for their cancer 6 years ago. So they're walking around every day, stepping on and off curbs, going up and down stairs, and they can't feel their feet. Okay, so starts to make sense why they're falling down more. Okay. So what we did was we also compared these women who were reporting neuropathy and put them through a physical functioning battery, asked them how well they were functioning and how often they were falling. And if they had neuropathy, they didn't function as well, they weren't as independent, and they fell more. So these women don't get seen by their oncologists anymore, but they're still suffering from side effects of their cancer treatment. So who is taking care of them? Right? Who is addressing this? And I hope all of you are thinking, we can prevent falls with exercise. Right? You already know that. I'm going to skip through this just for the sake of time, but just to tell you that we saw gait changes that look like older walking patterns, right? And people had trouble standing up out of a chair. So real functional things, right? So what happens to people with cancer? I've told you all these bad things, right? All these side effects and symptoms and bad outcomes, and what's happening when they're in the clinical system. Well, this is how all of these things are managed, right? Either with medication, right? Or not at all. right? There's no pill to prevent falls. There's no pill to prevent muscle loss, although they're really working on it. Right? There's no pill to prevent fat gain. Right? There's no real standard of care to help these, that the doctors don't really have to do anything about these. It's not standard treatment. Right? So this is what people are left with. So your bells and whistles and everything should be going off, but exercise can cure all these things. Okay? So we know all the benefits of exercise for people without cancer. Right? We know all of those. So that is what has really fueled the field of exercise oncology, which is, wait a minute, we know all the benefits of exercise, and we should use it to address all of these problems that are affecting people's quality of life after cancer treatment. So that's the field I work in, and that's what we've been doing, right, for the last probably 15 to 20 years now. And I'm going to show you where we've been at and where we're going, which we do have guidelines right now. So in 2009, a roundtable from the American College of Sports Medicine gathered together, looked at how many studies were done, and tried to put forward recommendations around exercise for people with cancer. Okay. There wasn't a terribly high number of studies, okay, but there was enough to act and to not do nothing. I probably didn't say that right. So we needed to put something forward to say, look, exercise has some benefits for people with cancer. We don't have the fit prescriptions yet, right? We don't necessarily know all the benefits, but we can't stay silent. So we have 2010 guidelines. They're in Medicine, Science, Sports, and Exercise, right? If you want to go find them, they're published on ACSM's website. And these are the guidelines. Follow the public health guidelines. Woo, okay. Right? Not super exciting. Every study that was done fell under the umbrella of our public health guidelines. Right? So that's what became the default. Right? In addition to make sure that if you can't achieve the guidelines, which most people can't, right? Stay as physically active as you can, avoid inactivity, and something is better than nothing. So we can at least encourage people to start moving at any point in their cancer treatment. You've got to move. Right? I think the big message from this publication was that it is the benefit of exercise outweighs the risk of any adverse harms of exercise for people with cancer. Right? And that's what was preventing exercise from being recommended for people. So it is safe, right? It's safe, right? But where do we want to go? So does that help you when you're working with a client who has prostate cancer, who is worried about his falls? Would you just say, let's get you to the guidelines, right? What you really want to do is give him a prescription. You want a prescription to give to this patient. You want to know, you've got neuropathy, let's do this. You're tired, let's do that. Okay? So what we want to move toward is exercise prescriptions so that we can be really targeted at affecting the outcomes that matter the most to the patient, right? Or to the groups of patients, right? So that we can prevent all of these poor outcomes down the road. Okay? So we want to move toward prescribing exercise as medicine or as therapy. And we would like, when I talk to the docs up on the Hill where I work, right, I tell them we can prescribe exercise just like you prescribe chemotherapy. Right? And that's what, right, when you follow directions on an aspirin bottle, it has frequency, intensity, type, and time. Right, so we want to use this the same way. Okay, I'm going to scream through this because I know you have it on a test and tell you the nuggets. Okay, I'm going to give you 2 examples. So right now the field, the American College of Sports Medicine in March of 2018 reconvened that roundtable. So now we got everybody and that much more, physical therapists and medical oncologists and exercise scientists and exercise psychologists and patients, all gathered in San Francisco in the spring of 2018 to try and improve those guidelines. Let's make them better than the generic guidelines that they are. Now that the research has exploded in this area, let's get specific. So by this time next year, you should see 3 papers come out in Medicine, Science, Sports, and Exercise, right? And one of those papers is going to get specific. And I'm just going to show you kind of the work that we're doing to try and get there. I don't have an answer for you because we are like literally actively working on it right now. In fact, after I talk to you, I think I'm going to go work on that. Right? Fatigue is probably the most ubiquitous, troubling, bothersome symptom to all cancer patients. Okay? And a lot of times it doesn't go away. So it can impact their ability to move and to be motivated to exercise, but it just affects all aspects of their life. Ability to work, care for their kids, etc. So this is also the area, the symptom that's been studied the most in exercise research in cancer. And this is a forest plot, and so any data point to the right means that exercise in these studies that are all listed here had a positive effect. It reduced fatigue. Any data points to the left means that it didn't work. Where are all the data points? On the right, right? Exercise is pretty effective at reducing fatigue, okay, overall. But we want to know, these ones that are on the line, are they different from the ones that are way over here? So we can really tell patients what to do, okay? So this is the woman that I had told you about that really inspired me and changed this field. But she did a study where women during breast cancer treatment exercised, right, about at least 15 minutes a day, as hard as they could push themselves. So it's called symptom limited. And their anxiety went down, they had no increase in their fatigue during treatment, and they slept better. Okay, so the very first kind of evidence, right, to show that it was beneficial. And then a newer study looked at, okay, so, we kind of have evidence that it might be effective, but how hard or how much? And so again, one of these studies where we're comparing a low to moderate amount with a higher amount. And we know for aerobic exercise, we'd see this dose response, right? The harder the work, the more fit you get. We don't see that with fatigue, right? So maybe you just have to do enough, and that's what helps, and more isn't necessarily better. Wouldn't a patient want to know that? Oh, I only have to do 30 minutes instead of an hour? That's great. Or I only have to work this hard. So I think our prescription for fatigue is going to look something like this. Right? Like a minimum effective dose. That's what the patient wants to see. Okay? Now I'm going to have to skip through all my fun stuff. These are the studies that we do up in Oregon. So I'm very interested in reducing fractures that are associated with cancer. We use a specific protocol that was developed outside of the cancer world. So our lab at Oregon State University also developed some of the exercise prescriptions for reducing fractures in people without cancer, and found that certain modalities are more effective than others, and in particular resistance training and impact loading on the bone is very osteogenic, right? It helps build bone or stop the loss much better than lower force types of activities like swimming and cycling and walking. So we did several studies in breast and prostate cancer patients and put them through our training program, which looks like this, right? So we emphasize exercises that have muscular attachment to the bones of interest, right? The hip and the spine are where people break bones, right? And then we have people jump up and down, just like basketball players and volleyball players and all the athletes who have really strong bones, right? So we're training people like athletes, but not quite as hard. And that's one of our guys, one of our prostate cancer guys, right? Look at that deadlift. You guys should be impressed. That's a faux weight, right? We have to bring the weight up a little bit so that he doesn't have to bend all the way down. But he's still really strong. So I'll summarize this without going through the data. We stopped bone loss with that exercise program in people with cancer, whose bone loss is not just happening because they're getting older, it's because of their cancer treatment. So we were a countermeasure, right, to bone-destroying cancer treatment with exercise. We didn't put them on a bisphosphonate. They were on all the anti-osteoporosis drugs. They couldn't be to be in my study, right? So exercise was medicine. They'd much rather do this. They feel way better than when they take some kind of medication. So the prescription for bone health in cancer, does this look like the fatigue one? It shouldn't. It's different, right? But if someone's really concerned about fractures because they're on testosterone treatment for prostate cancer, let's train them like this. If it reduces their fatigue, even better. I'm going to skip this and cut to the chase. So this is the slide I showed you before about how we manage side effects and symptoms from cancer treatment currently. Oh, look at exercise. Right. Does everything. What we want to move toward now is this prescription. right? What's your concern? Here's your prescription. Okay. I'm gonna just nutshell this. These are our kind of dosage, like a dose response, right? And there are different benefits from more exercise in some cases, except for symptoms, which I just showed you, right? So depending on the outcome, there might be a recommendation, start here and let's aim for here. Okay. You guys can read through this, but you basically know what the different benefits of different modalities are. They're showing, right, the same colors in cancer. And then I'll skip this, except I'll give a little plug. These are our guys that, you know, we do a lot of group exercise because there's something very effective and powerful and motivating for people who are in a room exercising, doing something healthy with people with a shared experience. And we found a great benefit from doing kind of group types of classes. But we've also shown that even if we give people a DVD of an exercise program, maybe with 3 different levels that they can follow, like I'm feeling tired today, I'm gonna sit in the chair, right? I'm feeling better today, I'm gonna get down on the floor and do something harder like a bridge, right? That individuals can self-modulate their tolerance and still exercise on a daily basis or near daily basis and get benefits, right? So we showed that when a doctor told patients to exercise, if he or she also gave them an instructional DVD to follow, then people actually exercise, right? So we know people need a tool. Okay, and what we want is that exercise is standard of care. Just like cardiac rehab, we'd like cancer rehab, right? You come in, you get diagnosed, the next thing you do is you meet with cancer rehab in the hospital. That's the goal where we want to get, right? That's what science, we need the science in order to get us there. Okay, so just to summarize, right? You know, hopefully you guys have kind of have an appreciation of kind of what the sequelae are of cancer, right? Beyond its threat to someone's life, that also impacts their quality of life. Okay. But that exercise can really play a role in improving quality of life, right? Mitigating the effects of treatment on their side effects and symptoms, and then excitingly might also change the course of their illness. Right? And what we need to move toward, right, we'll keep doing the science in the lab, but let's also think about, okay, once we get all of the evidence and the recommendations, we need the resources in the community for these patients to be able to have access, right? So being able to have programs in hospitals, in communities, right? And to have a workforce. So those of you who are, I think you have a fitness trainer track, I would encourage you to think about attaining your cancer exercise trainer certification through the American College of Sports Medicine, because that will help you, right, be part of the workforce to receive all of these individuals and really help them through their cancer experience. Okay, so thanks for your time. Okay.
So thank you very much, Dr. Winterstone. I would like to introduce next speaker, Dr. Linda Wilkin, who is our faculty and your teacher, professor. And she, when I first met her, it was during my interview, giving a presentation, a teaching lecture in her class, which was clinical exercise physiology. And I was very impressed by the students when I was being interviewed, wondering if I ask these questions, students gonna answer or respond to me. But they did, so it helped me to go through with my teaching lecture smoother than I thought. So I wanted to thank again for Dr. Wilkins that training and teaching students with a good background teaching the clinical exercise physiology. And I'm here. And one thing that I always noticed with Dr. Wilkin was she didn't look stressed. Past 2 years I've been here, I just see her in the hallway, she just like stressed. And then I found out later that she was from the electronic industry, working with Steve Jobs, how miserable the life was at that time. So she could be very happy teaching and interacting with you students. So I wanted to, I learned a lot from her. I didn't know that she was diagnosed with the breast cancer at the same time. So today, she's going to share her personal experience and stories about her past few years of experiencing having breast cancer as an exercise physiologist, as a scientist, retired professor from CSU San Bernardino. So it's going to be another aspect, not about the science research-based experience, understanding the effect of exercise for the breast cancer survivors, but more of the personal approach and experiences. So I would like to welcome Dr. Wilkin.
So, like Dr. Johnson said, I retired from Cal State San Bernardino. So while I was teaching down there, which I'm going to guess it was about 10 years ago, I had a mammogram and they found a lump in my breast. So I went and they said, oh, it doesn't look like cancer. We'll check it again in 6 months. I said, no, we won't. I said, we'll check it now. So I had them do a biopsy and it was benign. So when they do a breast biopsy, they put a marker. So they put this little titanium marker in your breast so you know exactly where they took the sample for what they did. So then when I got here, had the regular little old mammogram, right? And I had just switched to Kaiser because my Cal State insurance had changed and I couldn't use what I was using. So I was at Kaiser and I was just visiting my new doctor at Kaiser. And he said, when's the last time you had a mammogram? I said, a couple of years ago. I wasn't too concerned about it. And so he said to me, well, maybe you should do another one. And at the time, over like the last few months, I had noticed that when I would take my bra off, particularly my exercising jogging bras, right, that hold everything like really tight, my right breast would be uncomfortable. So I wouldn't want to say that it was extremely painful or anything, but I would just say it was uncomfortable. So I mentioned that to him that, that was occurring. It was just kind of uncomfortable. I said, well, we need to get you for a mammogram. So they sent me directly to mammogram. Yay, Kaiser. I was more than impressed with Kaiser. And by the time I was walking to my car, they were calling me. And they said, you need to come back and come back tomorrow. So I went back. It's not on, I don't think. I don't know what's going on. So I went back the next day and they did another mammogram, and most of you have not had mammograms yet and they are quite pleasurable. They smash the crap out of you, and occasionally, particularly my tumor is that the problem? That's not, okay. So my tumor that had been found with the first mammogram and they had sent me for the biopsy, or that I demanded the biopsy, it was really close to my chest wall. So when there's one really close to your chest wall, now it's really difficult for them to get a good mammogram. So now they use their sort of regular smashing tool, and then they use a newer smashing tool that smashes you more. So I got smashed twice when I went for the first mammogram, and then they called me back and they smashed me twice again. I think maybe even 3 times that second time. But then they did an ultrasound. And so then they showed me the ultrasound, and you could see that the tumor was sort of this messy thing. And instead of a nice little round body in there, it was kind of this messy thing. So I said, okay, we're really uncomfortable with this. So we went to go biopsy. So they sent me straight to biopsy. Well, the interesting thing was when they did the biopsy, they actually pulled the marker from the original biopsy. So now we know it was the exact same tumor. So I'm going, okay, why did my benign tumor become cancerous? So I'm thinking about this all the time, right? So of course they then set me up for surgery right away. So they removed the tumor, and of course they didn't get the margins as clear as they wanted them, so they let me come back and they took another big hunk. So that was lots of fun, right? Getting 2 surgeries. So then I got an appointment with the oncologist. So I went to see the oncologist. So now I was on hormone replacement therapy. I love hormone replacement therapy. I miss hormone replacement therapy. It made my life so nice. But as soon as they took me off of it, I immediately am in a hormonal turmoil. So it was ugly. So when I went to meet with the oncologist, I was by myself, and I walked in and she said, did you come all by yourself? So now I'm like, why was someone supposed to come with me? I'm like totally freaked out. So after I left the appointment with her, I went and sat in my car and cried. And I am not someone who typically cries, but it was that hormonal turmoil. And her saying to me, did you come by yourself? I mean, come on, clinicians really need to be a little more sensitive. I mean, here I am, I just had 2 big hunks of my breast removed. So I'm really, kind of not too happy about that. And I'm facing breast cancer and you say something to me like, did you come by yourself? It was very annoying. So then I met with the radiation oncologist. So the oncologist told me, you need to do radiation, you need to do drug therapy. So I meet with the radiation oncologist, and so he told me all of the lovely things that happen to you with radiation, and there are many that you didn't get to go over, even all of them. Can change the consistency of your breast, it can become harder, and the color can change, and you can get burned, and your lung, if it's on the left side, your lung can get damaged. If it's on the right side, your heart and your lung can get damaged. So it just kind of goes on and on. And they wanted me to do this 5 days a week for 6 weeks. Well, first of all, she said, I don't know, I have a job. You all expect me to be here. So, how am I going to do 5 days a week for 6 weeks of this horrible thing that is going to actually cause me lots of problems as far as I could see? So, I left that appointment. So then I start doing a lot of research. So I start researching radiation and cancer. And there are a lot of interesting studies out there. One of the main studies that influenced me was a study that was done in Canada. And they do 3 weeks of radiation versus 6. And they did a study that compared the 3 weeks versus the 6, and the 3 week was just as effective as the 6. So I'm going, well, then why are we doing 6? I'm not too happy about that. So then I looked at another study, and I'm not citing the studies for you, but just trust me that I read peer-reviewed journal articles, like we make you do. So it was a study that looked at what happens with radiation, and there was a study that took the position that if there are any cancer cells left over in the breast when they do radiation, that those cancer cells will actually leave the breast and go hang out somewhere else in your body, and then after the radiation is over, they'll come back to your breast and be more aggressive. So I thought, well, I don't think I like that. That doesn't sound too hot. So then I spoke to a friend of mine who had radiation and the drug therapy, and she said, well, I had about 20 hot flashes a day, and my hair would be soaking wet, and I couldn't put 2 thoughts together. And I thought, okay, I don't think I like that. How am I supposed to teach if I can't put 2 thoughts together? So I didn't like that. So then I finally sent the radiation oncologist an email, and I said, is it possible, I ran our DEXA, dual energy X-ray absorptiometry machine, right, down in Southern California. I did 2 major studies with that machine, which meant that I sat by that machine a lot. So I was exposed to a lot of radiation during the time that I was doing that study. So I said to the radiation oncologist, could my exposure to radiation through doing all the studies that I did with our DEXA, could that have caused my benign tumor to become cancerous? He said, it's possible. So I'm like, and you want me to do radiation? This is just not computing in my brain. So the fact that the tumor could have become cancerous because of the radiation, all of the studies that I looked at that talked about radiation and what I thought were not great, interesting things about it. Plus, I looked at another study as I was preparing for this talk that was from a journal called Stem Cells. It was published in 2012. And they said that radiation caused reprogramming of breast cells, that cancer stem cells were generated by the therapy. So, and even your talk just added more fuel to the fire for me. Why would I do radiation? Why would I do drug therapy? I was 68 at the time that I was diagnosed. I'm 71 now. I also looked at a study that looked at women over 70, and their survival rate, whether they had radiation or didn't have radiation, was the same. So, I'm thinking, I kind of like the quality of my life, I'm not really excited about changing the quality of my life. I don't know how much life I have left, but I would kind of like for it to be good quality life. So I decided no radiation and no drug therapy. I decided to take my chances. And the other thing that I did was I emailed the oncologist and I said, how do you know when someone is cancer-free? Because you always see, I kicked cancers, you know what, I'm cancer-free, yay, 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 I'm celebrating. So she said, we don't. She said, theoretically you are, because they had removed the cancer, right, and they had taken lymph nodes and the lymph nodes were clear, so that means that the cancer had not spread. So theoretically, I was cancer-free. So all of that, and then all of the side effect information just made me personally decide I did not want to compromise my quality of life. I, again, don't know how many years I have left, hopefully a lot, but I decided not to do it. And I exercise. Isn't that great? I'm an exercise physiologist and I exercise. So I always say I have to practice what I preach. So, I have pretty good lifestyle. I pay attention to things. I eat right, I exercise, I sleep well, I have low stress because I don't work in corporate America anymore. I love being here. So, I think that all of that really works in my favor and is really good. So it just didn't make sense to me to do all of those other things. So let me just tell you a little bit about my cancer. So my diagnosis was invasive ductal carcinoma. So a carcinoma begins in the skin or in the tissue. And sometimes, so invasive means that it involves other tissue, it invades other tissue. So it sort of got out of my ducts, right? It's the most common type of breast cancer. 80% of breast cancer is invasive ductal carcinoma. About 180,000 women a day are diagnosed with this cancer. It was not in situ. In situ means it stays in its original place, so mine didn't stay in its original place. It kind of, remember I said when they showed me the ultrasound, it had all these kind of fingers out from it. It wasn't pretty and round. They stuck this wire in my breast. They did another mammogram, smashed me again, and stuck this wire into the tumor to guide the surgeon to make sure that the surgeon got the right thing. So they look at cell grade, and the cell grade is about how the cells look different from normal cells. So my cell grade was 1, which meant it looked a little bit different. So it wasn't awful. And then stage looks at the size of the tumor, lymph node involvement, and has it spread to other tissues. Mine was stage 1, so it hadn't left the breast. It was slow growing and it was really small. It was 1 2/10 centimeters, so it was a relatively small tumor. It was estrogen receptor positive and progesterone receptor positive, which means estrogen would make it grow, progesterone would make cancer grow. It was not HER2. And HER2 is the really nasty breast cancer. HER2 is called human epidermal growth factor receptor 2. And it's actually about genes, and that the genes that play a role in the development of breast cancer. The genes have proteins, and if they're doing what they're supposed to do, they keep cells healthy and keep cells growing normally. But if it's cancer, then it starts causing cancer to grow faster and to invade other tissues. So I was really fortunate. So, when I looked at it and thought about it, I thought if you could say anything good about breast cancer, everything about mine was good. It was small, it was slow growing, I was old when I got it. I just looked at it from a positive perspective. One thing that the surgeon said to me, which is disturbing about, again, a medical community, the surgeon, I asked him, I said, okay, so when can I start exercising again? As soon as the surgery's over, I'm like, when can I exercise? So, he said, you can walk whenever you feel, okay. I said, well, I lift weights. He said, well, you could probably get back to it. I said, but I lift heavy weights. And he said to me, well, you don't want to do that. So I wanted to say to him, I'm an exercise physiologist, you're an MD, that's my decision. So I went right back to lifting heavy weights. And 2 days after my surgery, I was walking. I was out for a 30-minute, as brisk a walk as I felt like I could handle 2 days after the surgery. So, I went right back to exercising as absolutely quickly as I could, which made the most sense to me because, as scientists, we know exercise is medicine. So it just made a whole lot of sense to me. So let's see, what else did I want to say about all of this? A lot of women get breast cancer. I was on a website called breastcancer.org. 1 in 8 women will develop invasive breast cancer over the course of their life. About 266,120 new cases are diagnosed a year. 63,960 of them are non-invasive or in situ, which is pretty, not too much to worry about, but they still treat it pretty aggressively. And then I want to inform you and make sure that there is a sort of a thing out there, I guess you'd probably call it a blog, called The Truth About Cancer. And it is extremely informative. The man that does it, his mother and his father both died of cancer, so he is now on a mission to find out what the heck. So he has traveled the world and talked to people who treat cancer worldwide, and worldwide cancer is treated very differently than it's treated in the United States. Most people worldwide would take a position that we treat it very barbarically, that we're, killing it with very barbaric techniques as opposed to nutrition and exercise and, things that aren't so barbaric, that are going to kill other cells in your body, that are going to damage your lung, damage your heart, damage who knows what. So I have none of the signs or the symptoms, none of the, issues from breast cancer treatment because I chose not to do it. The quality of my life, other than missing part of my breast, which is not fun. That wasn't nice. I didn't like it. But, the quality of my life is good. I have as much energy as I've ever had. I'm not running around. I see the oncologist every 6 months, which is just a joke and a waste of my time. But I go see him anyway. And I have chosen to not do a mammogram for the first 2 years. I just did one, not happy. Don't want to do them. I've done thermography, and thermography doesn't give you everything you need to know. So I finally decided, okay, I'll go do another mammogram. But I'm not going to do a mammogram every year. I'll choose to do them when I think, okay, I'm ready to do one. But there's still some pain associated with the surgery. The nerves are regenerating, and I shouldn't say pain, discomfort. So there's still some discomfort in that breast from the surgery, but again, it just gets my attention, and I'm like, oh yeah, I know what that is, and I just go on about my life. So that's sort of it in the nutshell, what it's like to be a breast, and I'm a survivor, I guess, but I'm alive, so that means I'm a survivor. All right, shall we do questions and answers?
So that's a really good question. So I showed you kind of the 4 most standard treatments for breast cancer, and I'm oversimplifying this. So you made a lot of important points. We didn't go over like staging of your cancer, which is kind of how aggressive or bad your cancer is, ranging from 0 to 4. 4 is metastatic cancer. That means the cancer has now traveled away from its site of origin and it's invading other parts of the body, and that person will probably die of cancer if you have stage 4. People can live a long time with stage 4 disease, but it typically ends up taking their life. So depending on the staging of your cancer, that will dictate what kind of treatment you get. So something like a stage 0 or 1 cancer for breast cancer gets treated less aggressively, so maybe not chemotherapy, I think, than like a stage 3 cancer would. But these are the conventional therapies, and we know that they are associated with these kind of intolerable toxicities sometimes and really affect people's quality of life. And the trouble, particularly with like chemotherapy, right, the most aggressive of them all, but pretty effective because it goes everywhere, tries to get all the microscopic cancer cells that can't be seen, right? So you might be cancer-free by all the diagnostic tests we can do, but it doesn't mean there's not little cancer cells that can't be seen or imaged, or we don't have good blood tests for cancer at all. It's what we need. So but because it is systemic, it goes everywhere and affects everything. So now what a lot of the drug therapies are moving toward is not to come up with another chemotherapy agent, but can we get much better at killing the cancer and not everything else in its path or everything else around it? So these are targeted therapies. And the challenge is, can you put something in the bloodstream and have that molecule know when it's attached to cancer or nerve or heart cell? How does it know? What's on that cell that identifies it as cancer versus something else, right? So there's these kind of things that are on the surface of the cells. So some of the targeted therapies are either trying to find the cancer cells and then do their deed, or are targeting specific mechanisms in the growth of cancer cells. So there are specific pathways that cancer cells use to grow. So another target might be, I'm going to get this part of the pathway that doesn't exist in other cells, right? And so targeted can mean that those therapies are better at finding the cancer cells versus other, or it's better at attacking a specific process in cancer growth that doesn't affect growth of other cells. They're usually given on top of conventional treatment. So what I've learned, I work in a cancer institute where most of the people that I work with are trying to develop the next drug. They're trying to cure cancer, right? Cure it. And what I've learned is it's a little bit of a fallacy that we're going to not give people chemo anymore and we're just going to give them a targeted therapy, because when you're doing a clinical trial, you can't not give people the treatment that's going to save their life. It is not ethical to do a study that way, right? I have this new experimental treatment and I'm going to try it on you and see if it works, and I'm not going to give you the treatment that we know that works. I'm going to give you this experimental one that I'm not sure that works. We can't do that kind of research in the US, right? Or most other countries. So what happens is that we give everyone standard of care and then they get the new experimental drug on top of that. Or it's given to people who are terminal and they have no other option but to try this new experimental drug. So targeted therapies are where the movement is. The other thing that I think is pretty cool, and it blows my mind a little bit because we didn't do a lot with genetics when I was in undergrad, and now you guys should all have it as a standard course. But every tumor has a genetic fingerprint, right? So it's called, like a breast cancer patient now gets a sample of her tumor taken and it gets oncotyped. So it gets genetically mapped. And different, not all breast cancers are the same. So even someone who has a stage 3B breast cancer, one woman's tumor can have a different genetic makeup than another woman's tumor. And so what that oncotype looks like dictates what kind of treatment she gets. And it may be that she gets less treatment. So we don't, oh, you've got that cancer, we don't have to give you chemotherapy, we can give you radiation therapy and Herceptin and this other drug, and that is better at treating your tumor type. So it's pretty cool how sophisticated it's getting, but you can imagine it just got infinitesimally more complicated, right? But there is a movement. I mean, even though I said we're giving these experimental drugs on top of conventional treatment, but I think the goal for everyone is to see, you know, can we treat and cure the cancer and maintain the quality of life? So, you know, over the course of the time I've been in our cancer center and the breast cancer clinic, they give less chemotherapy than they used to. Right. So, you know, things are exciting, but not happening fast enough for everybody. Yeah.
I was particularly interested in the cancer exercise training. Could you go a little bit more in detail of what that would cover in that certification, or what the field applications for that individual would be in the professional world?
Yeah, it's a very good question. So the cancer exercise trainer, so the American College of Sports Medicine several years ago started these additional certifications kind of specialty certifications. You might know them more than I do anymore.
But I know there is one.
Right. So it didn't go as far as they had hoped, but what was developed was a cancer exercise trainer certification. And what has replaced HFS now?
Oh, I don't know.
Do you know?
They keep changing it.
They keep
so
changing
much.
it.
I'm constantly confused.
You know.
I think it's to sell us books. But.
Yeah. So it used to, there was ACSM, Certified Personal Trainer, and then it used to be Health Fitness Specialist. And I know they've replaced it, and I'm sorry, I don't know
It's probably maybe clinical exercise physiologist.
what that equivalent, I think that's maybe one level above. But so in individuals who have above a personal training certification from the ACSM can sit for the cancer exercise trainer exam and get that certification. And what it does is it's a knowledge-based test. So unfortunately, it doesn't have a practical component, because I think you should work with people with cancer in addition to knowing more about them. But it gives you enough knowledge to be able to understand kind of the basic knowledge about cancer. It's pathophysiology, common types of treatments, common types of cancers, how it impacts somebody's tolerance for exercise, and then how can exercise benefit that person. So that you, as a fitness professional working with a client with cancer, right, can not only be informed, because they want you to know that you know about cancer, to trust you, but that you know what is good for them and what might be harmful for them, and then you know how to train them appropriately. So there are textbooks that you could buy to study for it, and there are workshops that are given around the country, basically kind of a classroom type of workshop to be able to teach you, right? I think that's probably a richer experience than studying out of a textbook, because you be able to have Q&A and interact with the instructor, but to prepare you to take the exam. And then once you have that, you get listed in a directory through ACSM, right, as individuals who have cancer exercise trainer certification. And depending on your setting, I think it really gives you an advantage, right, over everybody else, because ACE doesn't have one, NASM doesn't have one. I mean, I think ACE might be working on one, but none of the other credentialing organizations have the equivalent yet. So I would strongly encourage you to do that, or to consider it. Yeah. Yeah.
I was wondering, with the way the research is going for exercise, like against cancer, do you think we might be able to change like how MDs are like prescribing exercise, like versus moderate to vigorous? Might change the way they're thinking about that?
Yeah, that's an awesome question. So I don't know if everybody heard it, but the question was, would we change the way that clinicians, well, A, that they recommend exercise? Yeah. That's the first thing. B, do they know what they're recommending, right? So here's the cool thing. Every time we brought 1,000 cancer patients through exercise trials, in-person supervised group exercise trials. And we bring them in kind of 50 at a time. And every time we start a new group of 50 in training, I ask them, okay, how many of you had your oncologist or a medical provider tell you that you should exercise? Almost all the hands go up. So that message, I think, for the most part, has reached the oncology community. Oh yeah, my doctor told me I should exercise, I should move. So at least we've flipped that first problem, right? And then I asked them, did they tell you what to do? All the hands go down. Every single one of them. So, I mean, I'm glad you're shaking your head. It's kind of an empty recommendation, right? Because the people who know how to exercise or were exercising for their diagnosis are probably still doing it, right? But most people, a lot of people who come into our trials are afraid. They think exercise is going to hurt them. They don't know what to do. They sign up for my trial because, oh, it's at OHSU and it's through the Knight Cancer Institute, and so I know I'm going to be safe, right? So many barriers for people. People walk into a 24 or community center and look at everybody and say, oh, that's not me. That is not me. I can't feel my feet. I can't think straight anymore. I can't follow an exercise cue, right? And so they walk right back out, and there's nothing else for them. So I don't know that the answer is going to lie with the providers. Because when we, at the round table, when we have the providers in the room and we're talking about a fit prescription for bone and neuropathy and lymphedema and weight gain and all of these things, they're just like, You're going to put one more thing on my plate. I've got to treat this patient. Oh, you want me to talk to them about their weight, and you want to talk to me about exercise, and all of it. The providers don't have the time or the capacity or the interest. I really don't. They want to, their success is treating the cancer.
They don't have the specific knowledge either.
And they don't have it. They don't get anything in medical school.
They don't study it.
Zippo.
You know, like my oncologist told me not to lift weights. I mean,
Yeah.
come on. He's discouraging me.
So, and
you don't exercise either.
Yeah, probably not.
actually, I found that the providers who are exercisers are the ones who are usually the ones who are most eager, and they kind of push patients to do it, but they still don't give them anything specific. And there's no warm handoff to an exercise professional, which is really what we want. So what the providers want is resources in the community to be able to refer their patients to. And I think what they want, the message, their most concerning message is, I just got to get my patient to move. So most of their patients are not like Linda.
Right.
Right. They weren't active, they weren't exercising before they got cancer, and they're sure as not going to exercise now, and they've gained 20 pounds. And so what the providers want is, what's the least amount of exercise? Just give me one thing. What should I tell them? Walk 15 minutes a day, 3 days a week. So that may be the first step. The other place that's interesting that we're trying to get providers to do, and we didn't talk about this, but is a referral chain, right? So what I have seen that's really troubling for me is that when I get women and men who've gone through cancer treatment that volunteer for our trials, they're all usually done with treatment, and they come in and they train, and my trainers and I and project director, we think, oh no, these people don't know how to move anymore. So people are walking into a training room with neuropathy and lymphedema and cognitive problems and tons of pain and limited range of motion, and they can't move anymore. And guess where they should have gone? PT. So I know a lot of you are thinking about PT school. So what we're trying to do now is to get referrals from oncology to physical therapy. And then when you guys are out in physical therapy, because you're exercise science students, you could probably also start prescribing exercise. Or have the physical therapist now prescribe them to an exercise physiologist or to community fitness program, so that, right, they can kind of take it over from there, but they can walk into your training room physically able to train. What we do a lot is refer people back to PT. Like, wow, you can't even do a squat, right? You tell people to come in and, you know, stand with your feet shoulder width apart and kind of soft knees, and they're like this. Right? And overweight, and please don't make me move because it's going to hurt. Don't hurt me. And so when you're like, take a big step to do a lunge, they're like, So what I've seen is just this whole big miss in clinics, from the MDs to rehab services, and then out to community fitness practitioners. And there's even a movement now in oncology that's for prehab, right? So you guys probably know that from ortho, right? So you can prehab people before surgery, and sometimes you delay surgery until they're strong enough to tolerate joint replacement or what have you. So now there's a movement to do prehab in oncology, but let's think about that because of what you said. Oh my God, you've got a tumor, we're gonna get it out right now. So where's the prehab space? There isn't any. In some cancers, there may be, like lung cancer surgery, they're willing to maybe delay the surgery until someone's able to get out of a chair. So there's been some like 6-week to 8-week prehab studies that between diagnosis and surgery to condition people, to put them in, they're usually like cycloergometry, kind of protocols, and see if we prehab them, do they come out of surgery better? And the data are kind of meh. But there's not very much. But what it may be too is the opportunity is to start two things. One, I think, is documenting a baseline for people. So if you can get them in and document their physical functioning, their cognitive functioning, and all of that, then you know, as they're going through treatment, where do we want to get them back, right? Rehab calls it return to normal living. If you go into PT, you'll talk a lot about RNL. But let's get them back there, or if not better. The other thing might be that it starts the expectation that we care about your physical and mental and everything else health as you go through treatment, and we expect you to get back to where you were. And so it might also be kind of a behavior prompt for our patients and everybody else to keep addressing. While the oncologists are treating the cancer, then the rehab team of OT and PT and everything is addressing all of the other issues. Yeah.
There's like so many other factors involved with cancer, like nutrition. How do you guys like analyze just being exercise as the causation?
Oh yeah.
Of like staying in remission or getting there? Or if there's any like studies that have all of that together, like nutrition, exercise, other medicines that you're taking, maybe natural supplements?
Yeah. No, that's a good question. Yay, a science question. Study question. So in my trials, because we're only intervening with exercise and not diet, we usually measure food quality and energy intake across the same time points as we're measuring outcomes. And then that way we can at least see whether or not people change their eating habits at the same time we were intervening on them with exercise, which we tell them, please. Yep. Yeah, so we do these evil things called food frequency questionnaires. If you've taken one before, some of them are like 50 pages long, and they're like, do you eat oranges? Yes, I eat oranges. How many oranges do you eat? What size are the oranges? Do you eat apples, right? And so they're like 128 pages long. So sometimes we put people through that, or we ask them to recall what they've eaten in a certain period of time, kind of assume it's representative of the rest of the time they're eating. A little risky. So then we can look at nutrient composition and total energy intake and anything you'd like to look at as a dietary factor. And then, okay, let's say it changes at the same time. So I'm doing a study on bone health, and wow, everybody started taking calcium supplements. Great, right? Same time I put them in exercise. So is it exercise or is it calcium supplements? What we do is fun with numbers. And so we control for that in our analysis. So we're able to say, after we adjust for this increase in calcium intake, do we still see this independent effect of exercise? So that's one way to do it. Sometimes trials will do what's called, another way is to add it in as an independent variable. Let's look at both. So nice trials are designed as what we call full factorial. So I'm going to have one group that gets exercise, one group that gets a dietary modification, one group that gets both, and then one group that gets nothing. And then you can see, is exercise alone as effective as diet alone, or is it really the fact that we combine the two together that gives us the most bang for our buck? And what's interesting is when you look at some of the studies that use what we call biomarkers of cancer progression. So we're looking not at the cancer itself, but things that get released in the blood that indicate the cancer's changing. Some studies that do these full factorial designs of diet versus exercise and diet, it's the diet component that tends to win more than exercise, which makes us think maybe it's weight, right? Usually these are like weight loss, through diet, weight loss through exercise, weight loss through exercise and diet. And it usually the dietary interventions are the most effective, because we all know it's really hard to make people lose weight with exercise, right? It's really hard. It usually fails, right? People always compensate, right? They either sit more when they're, right, if they're an exercise group, they usually sit more when they're not in their exercise study, or they eat more because they exercise, and so they usually don't work. Right? People have to change their diet.
Yeah, I was just, well, I mean, you're more of the exercise component, but do you know anyone that are doing that with, like, while they're on chemotherapy, or, you know?
Which is a hard, very hard time to tell someone not to eat.
Growing up, yeah.
I mean, yeah, because usually people have a hard time eating. So there are studies. Look at the WHEL study, WHEL, which was a study in breast cancer using dietary-induced weight loss, and to look at survival and these biomarkers as an outcome. So in a nutshell, the studies really haven't shown that dietary-induced weight loss is changing survival outcomes. However, compliance to the diet is really poor. So when we do a big study and we're going to try and make a big public health recommendation, the one thing we have to do is look at everybody who was enrolled in the study and got an intervention, and whether or not you really did the intervention or you didn't, we're going to count you. It's called intent to treat. And then sometimes we'll say, all right, let's only look at the people who actually did it and did it well and got the weight loss. And that's called like a sensitivity or per protocol analysis. Right, but that's a special group. And they may not look like the whole population or sample you're trying to look at. So usually in the intent to treat from the from the dietary weight loss studies are not looking really promising, but they think compliance is the issue. People just aren't doing the diet. Of those people who do the diet, we start to see a change. So, it's hard. Human behavior is hard. You guys know that. Changing behavior. We didn't even talk about motivation or barriers to exercise and all of these things, much at all. But that's a whole nother thing that you have to consider. And I'll tell you my own experience, being really kind of naive as a scientist at the beginning, was I don't care if people are motivated to do my program. I want to study whether or not my program works. Right? Like an efficacy trial. Because I'm not thinking about down the road. I designed this really cool program and I want to see if it works. And what I've been humbled by is that I have a really cool program that really works and no one wants to do it. Because it's too hard. I mean, you saw what it looks like. Weighted vests, deadlifts, and jumping up and down, and so I have to figure out, you know, what am I going to do with this? How worthwhile is this science? And so I'm starting to change my tune a little bit about, you know, it pains me when you're a scientist, right? Like, I want to control everything and do the most effective intervention, but, you know, I've met a lot of people now, and I want them to actually be doing this stuff. So now when we design programs, we really think about, is this a program that the Y could pick up, and you know, that, I don't know, is it San Jose Community Fitness Center, whatever your community adult fitness programs are called, and that people could do. So we've got, in exercise science, we kind of have to ride that fine line. And now there's a whole field called dissemination and implementation science. Whole another body of knowledge you guys can learn. And so you take these efficacy trials and now you put them out in the community and you kind of take the gloves off. Like, here's my program, YMCA, go implement it. And I'm not going to control it. I'm going to watch what you do. And the reality is, so I've started to work more in the community, and what people really do, I can tell you, you guys know, I don't like that exercise. I'm not going to do that. My people don't like that. I'm going to do this one. And you start changing it. And all of a sudden, it's not my program anymore. And so, should you really be calling it a fracture prevention for people with cancer class anymore? I don't know. But people are taking it because you're selling it. So now that like the next stage of our field, besides continuing to try and do, how does exercise work and what does it work for? There's another group of people that are like, okay, we have all these great programs. How do we put them out there? And how do they change? And do they still work? And does anybody do them? So there's this whole field trying to study that whole piece, which I've been kind of blissfully ignorant. I don't live in the community, thing. But now we're, right, like kind of facing the truth, which is we have to create accessible, practical programs and then see, does that work? Right? And if not, maybe exercise isn't the answer for everything. If I can't if I can't get people to do a program that prevents bone loss, maybe they really need to take osteoporosis medication. I don't want them to fracture. You don't want them to fracture. Maybe you can stop their falls instead, which is more practical. So.
But again, the medicine is not that worry after 3 years.
Yeah. Well, there's that, right? I mean, right? There's all the side effects of the other medications. We'd really like people. The other thing I think is that, at least what I've heard, is a lot of individuals don't want to take any, once people are done with their cancer treatment, they're kind of done with Western medicine, period. And so we like to give them options, right? And exercise and nutrition can be a viable option that is a non-pharmacologic alternative, right? As long as they're highly motivated to do it. Oops.
I want to thank our speakers. One last thing. You guys are here and you're leaving, but I found the quote from you, from a video. I told you I stole. So she said, I want our research program to create a culture change so that exercise become a part of standard treatment for every person who goes through chronic illness so that they can recover faster and live better.
Yeah.
We are strong.
Yay.
What do you think? Okay, thank you.